Good morning, all. This is the HAPI seminar at its usual time and place. So the Health in the Public Interest Program is a one-year MS program that we have at Georgetown University that emphasizes let's say, the non-medical factors that affect health, the social determinants of health. And today we're going to hear from Dr. Susan Molchan, who will be introduced in a moment by our student moderator. And meanwhile, I just want to explain that this is a seminar being attended by close to 45 people today. So we're going to ask that everyone remain muted unless the speaker asks you to unmute for some reason during her talk. Otherwise, we'll open it up for discussion when she's done, which will be about 45 minutes after she starts speaking. And that'll be followed by questions by students or discussion points, and then by more general questions from the balance of the audience. So thanks for attending. Next week, you can come back and hear Dr. Peter Laurie talking about advocacy and advocacy tips for outsiders, I think is the approximate title. And so without any further ado, this is Chetiana, our student moderator, and she'll be introducing Dr. Molchan.
Yeah, hi everyone. Today we're joined with Dr. Susan Molchan. She's a geriatric psychiatrist and adjunct professor at the medical center, and she collaborates with Pharmed Out, research and education project that supports evidence-based prescribing. She spent years in clinical practice working with Alzheimer patients and did research at the National Institute of Health. She focused on clinical trials, biomarkers, and brain imaging. And she also spent 5 years as a medical officer at the FDA. And a fun fact about her is that she loves to hike and she's an avid traveler. And she actually just learned that travel is good for brain functioning as well as hiking. So I'm gonna turn the floor over to her.
Thanks, Chet. So I'm happy to be back at HAPI. So mild cognitive impairment, or MCI, it's a clinical diagnosis that's been expanded in the past couple of decades to include more and more people with less and less impairments. And drug companies and others want everybody over 65 years old who loses their keys to think they have it. And that's a lot of what I'll be talking about today. At its core, mild cognitive impairment means that a person's cognition or brain function is slipping. Usually memory, but also losing one's train of thought, difficulties planning, trouble finding objects, trouble coming up with words. That's an annoying one. These last two happen a lot. Trouble with finding words and objects. They happen a lot with normal aging, but just occasionally. Next slide, please. So even mild cognitive impairment, though, does not interfere, I'm sorry for the blurriness here, does not interfere with a person's everyday function. This is what separates this diagnosis from dementia or an Alzheimer's disease diagnosis. We'll talk about the difference between dementia and Alzheimer's disease coming up. Which MCI can be a prelude to. People with MCI don't have trouble with shopping or finances or planning and preparing their meals, for example. So there's a spectrum between normal aging, any preclinical, forgetting things just a little bit, to mild cognitive impairment, and then into dementia, which has a spectrum itself, mild, moderate, and then severe. Now, it is true that about 15% of people a year with MCI will go on to develop dementia. That's close to about half of them in 3 years. Others with MCI, on the other hand, will go back to normal some for unknown reasons, and some because they have treatable conditions. And I'll talk about those. Next slide, please. Some treatable causes of MCI are listed here. Depression is one. As a psychiatrist, I would see people who were in nursing homes with a diagnosis of dementia, of Alzheimer's disease, and they were depressed. They would be treated with an antidepressant and start to feel better, and sure enough, they'd be back to their old selves and could go home with their spouses. They were just depressed. So depression it can have memory impairment, apathy, all the things that can look just like dementia in an older person. Thyroid problems, kidney, liver problems, sleep apnea, stroke, and other structural brain problems, vitamin B12 deficiency, infections, drug side effects, especially things like benzodiazepines, Xanax, Valium, Ativan, anticholinergic drugs. The most familiar of those to most people is Benadryl, and some drugs for overactive bladder. Next slide, please. So dementia is a very general term, the global term, and traditionally about 60% of what we think of as dementia is called Alzheimer's disease. And the definition of that has changed over the years as well, in large part also a marketing thing. But about 60% of what we think of as dementia is Alzheimer's disease. About 15% is blood vessel disease or vascular dementia. Basically the same thing that happens to a lot of people's hearts, narrowing of the arteries, hardening of the arteries. About 6% is dementia with Lewy bodies. These are abnormal protein deposits, about 1% frontotemporal dementia, and then a number of other more rare dementias. People with Parkinson's disease, most of them go on to develop dementia, HIV, alcoholic dementia, hardening of the hippocampus, Huntington's. Really though, most people with dementia who are in their 80s, most people with dementia are in their 80s. It's a mix of things. Just like anything with aging, it's lots of things change, lots of things, and it's not in the good direction. Lots of things break down. So most people with dementia, it's a mix of the changes that are associated with Alzheimer's, with blood vessel changes, with Lewy bodies, lots of different things. Next slide, please. The biggest risk factor for MCI and dementia is age. That's the bottom line, and why people have become more concerned about that. Next slide, please. Is because and I'm sorry for the quality of this slide, but it's the world is aging, especially in Western countries, in North America, in Europe, in Asia, Japan, I think it's and Korea especially, China. They have many more older people than younger people. The United States, and it's a big market. Dementia is a big problem. So, and this has been known for, the past 30 years. People are having fewer babies, and the only continent where they're, it's not aging as fast as Africa. They have a lot of relatively much more younger people, but we're going to be seeing a lot more older people in the coming decades, and this means less of a workforce, less of a taxpayer base. It's a huge problem, and again, with the #1 risk factor for dementia as aging, there's been a big push for figuring out what to do with dementia. Okay, next slide. So just to look back historically, what does Alzheimer's disease mean? On the right is Dr. Alzheimer's, and on the left is his first patient. She was 51 years old in the early 1900s when he described her. She had memory problems. She was paranoid, delusional. But again, she was 51 years old, as were the other patients that he described. He associated the changes that had happened with her to the pathological changes in her brain. Next slide, please. Her and the other patients that he described, they were also all in their 50s. And they're illustrated here. The big glob on the lower right part of the slide is amyloid. And that's one of the characteristic features of Alzheimer's disease. It's an abnormal deposition of a protein called amyloid, and there's lots of that in what we call Alzheimer's disease. And the little flame-like darker deposits are neurofibrillary tangles, and these are deposits of microtubules that have gone bad. Microtubules are made up of tau protein, and they just become discombobulated and start to curl up in a bad way and deposit within nerve cells. And what happens is the nerve cells die. They can no longer synapse with each other. And next slide, please. And with the cell loss, the brain actually shrinks and the symptoms occur, the memory loss and other symptoms occur with Alzheimer's disease. The thing is, though, even people with normal aging, with lots of other diseases, have these pathological features, have the plaques and tangles in their brains. It's not specific to Alzheimer's disease. People with Parkinson's disease have it, with other dementias, and like I said, we all get them to a much lesser degree with normal aging. Next slide, please. But this amyloid protein, these little deposits in the brain, they became perfect targets. They sequenced the protein. They were able to grow it in the brains of mice and show that the mice got, what they call, mice dementia, and they were able to cure the mice and clear the amyloid from the brains in the mice. It was a perfect little target to, next slide, please, to develop pills for. So this has been the effort for the past 30 years in Alzheimer's research. And if you were going to do Alzheimer's research, you better submit your grants for something to do with amyloid, or don't even bother. So for the most part, that's starting to change. But that's been the holy grail, is a pill to knock out amyloid for these people with dementia, to almost, it's like almost to the exclusion of everything else. The amyloid crowd just really took over the field. Next slide, please. As part of that, they developed PET scans with radioactive nucleotides that could label the amyloid in living brains in people. Pretty cool. So the scans on the top show the amyloid in red, a normal cross-section of brains in the lower half, showing very little amyloid, so normal on the bottom, someone diagnosed with Alzheimer's on the top. The problem is the set of brains on the top could also be someone who is perfectly normal. Like I said, we all have plaques and tangles, and some people can have quite a lot of amyloid and live with it for years and be totally cognitively normal. That the amyloid does not correlate with cognitive problems, but still, the amyloid juggernaut went on and developed drugs to clear the amyloid. Drug after drug, failure after failure, but they continued on. Next slide, please. They developed other biomarkers besides the PET. They measured varieties of amyloid in the cerebrospinal fluid, the component of the neurofibrillary tangles, the other deposits in the brain, cerebrospinal fluid, tau. They're developing, their holy grail is blood biomarkers. They want everybody to get a blood test that will tell them earlier and earlier so they can start these drugs, as soon as possible. They try to do that now, again, pushing back what they call people with MCI now, as they define them as having Alzheimer's disease when they see some amyloid in the brain. Again, so people with clinically with MCI, if they have amyloid in the brain, they call them Alzheimer's disease now. And this is who they included in the clinical trial for some of the drugs that they have approved. Next slide, please. And again, part of this is up and down the whole development of these drugs. There's a lot of money involved, billions of dollars. And most of the academics in the field are consultants for the companies developing these drugs, including those that advise the FDA. And there's actually an interesting paper coming out soon that showed for one of the drugs that some of the advisors were actively advising taking consulting fees from the companies on the advisory board to the FDA. For people who don't quite know how the FDA works, for a lot of drugs, including for those that where the decision on whether to approve or not might be controversial, the FDA constitutes an advisory board, mostly of doctors in the field, and a few other people. And this advisory board makes a recommendation on whether to approve the drug or not. The FDA usually goes along with that. So it happened with these anti-amyloid Alzheimer's drugs, and there's just, as across the whole field, including up through the advisory boards to the FDA, just a lot of conflicts of interest, financial conflicts of interest involved with this. Next slide, please. The Alzheimer's Association is also a very conflicted group. They're the primary advocacy group, supposedly patient advocacy group for Alzheimer's disease. They've been around for 60 or so years. They take a lot of pharmaceutical company money as well and try to have people think that they have Alzheimer's disease and MCI. One of their statements, let's just look at it. They say 1 in 10 people age 65 and older has Alzheimer's dementia. And while that might be true, most people with dementia are in their 80s. So they're kind of spreading out the statistic, saying, starting at age 6, they're emphasizing the 65 number rather than, and trying to alarm people much younger than need be. Next slide, please. And in their pictures, they show people, presumably the woman on the left and the woman in the middle here are the people of concern, and they're clearly not in their 80s. I don't even think they're 60, but they're raising alarms to younger and younger people. Are you losing your keys? Did you forget a word today? They're just raising alarms and wanting people to go to their doctor and try these drugs, even though the drugs, and we'll talk about this, don't work and have significant safety problems. Next slide, please. Again, pushing the diagnosis back earlier and earlier and earlier. Next slide, please. So, like I said, there's been a lot of studies. At first, they thought the studies of these anti-amyloid drugs weren't working because they did them in Alzheimer's patients, and they were saying, "Oh, well, we're testing the drugs too late. It's too late for these people." So they started doing them in unimpaired people, who had amyloid in their brain, early, MCI people, and in people who were genetically predisposed. They still didn't work. And this is an example of one study called the A4 study. Next example. Next slide, please. They did them in a study of a group of patients who had as Alzheimer described, the early onset familial form of the disease. They definitely did not have the disease, but these people, it's an extended family in Colombia, were sure to get the disease. They had a genetic predisposition, and these people who make up about 1% of dementia cases, of Alzheimer's cases, are sure to get the disease and to get it early. They followed these people for years on the drug, a placebo-controlled good trial. The drug didn't work. And the highlighting here is an example of three of the researchers, some of my former colleagues, and it's highlighting their consultant, the companies from which they took consulting fees. And there's at least 10 companies under each of them. These are full professors at universities. So they make a very good living, and I'm sure very, very busy, but it just shows the rampant conflicts of interest in the field. I don't expect you to read them, but it's a lot of extra, a lot of conflicts of interest from multiple companies, mostly consulting fees, some funding of their work from other companies. Next slide, please. Okay, so this slide lists the anti-amyloid drugs, which are monoclonal antibodies that lessen the deposition of amyloid in the brains, that have been approved by the FDA. The first one was the one there that begins with an A, aducanumab. It's been taken off the market. It just wasn't selling very well, especially since the other two came out. So they profess to have all slightly different mechanisms that they'll go into gory detail about if you want, about how they inhibit amyloid from depositing so much. But next slide. This is just an example of how little they do. This is a primary outcome measure for one of them, lecanemab. That study went for 18 months. That's the bottom horizontal axis. And the line over that time for lecanemab is on the top, placebo is on the bottom. And the difference over time was statistically significant. It's true, but not clinically significant. And that's an important distinction to make. So while they were able to show a statistical difference, it didn't make any difference. Patients and their families couldn't really see any difference. This is over 18 months. It did clear the amyloid from their brains, to some degree. Again, we don't know if amyloid has anything to really do with what happens because it really doesn't correlate with cognition, and it's never been shown to be a cause per se of Alzheimer's disease. But it just didn't show any clinical significance. But because it cleared the amyloid from the brain, the FDA approved, based on that evidence primarily, the FDA approved this drug, and the other two drugs based on similar evidence. Next slide, please. So some patients, I've heard them, in interviews say, well, I'm having these memory problems and I saw my mom suffer with this. I'm going to try it. It can't hurt. It can hurt. And this is what these drugs do have very significant side effects, including death, and they're listed here. The most significant side effects are stroke, brain bleeding, and brain edema, and insignificant numbers. So strokes, they've seen strokes in people. So some of these people are going in, they have pets, they have concerns, they have a PET scan, they're told they have lots of amyloid in their brain. They may have perfectly normal cognition, and they develop concerns, and they're going in and taking this kind of risk. So they're going from normal to perhaps then having a stroke. Next slide, please. Not only that, there was a paper, last year, I believe, showing that all of these drugs, and this has been known since quite early on in their development, that they cause accelerated brain volume loss. And I'll quote from the paper, that mild cognitively impaired participants treated with anti-amyloid drugs were projected to have a material regression towards brain volumes typical of Alzheimer dementia, about 8 months earlier than if they were untreated. That means, next slide, please, that their brains are headed to looking like, does this look familiar? Like this. This is just what we don't want. This is what we're trying to keep away from. So their brains with these drugs are atrophying, and nobody knows exactly what this means, but it's just in the opposite direction of what we want. So at first they thought, well, maybe it's because they're taking out, sucking out all this amyloid, and that's causing, a little shrinkage, but it's not a little shrinkage for one thing. And they've shown that that's not what's happening. So they're not sure what's going on, but all of these anti-amyloid drugs that are purportedly being used to treat Alzheimer's disease, whatever the stage, very early on in, people with MCI, cause brain atrophy, brain shrinkage, which is just the opposite of what we want. This is not in the FDA label. People are not warned about this. And researchers, physicians who administer the drug do not understand it. I doubt that it's in the consent form of people who are being administered these drugs, since it's not in the label. It was hardly talked about. I listened to the lecanemab advisory committee meeting. It was hardly talked about at that. But it's of significant concern to some of us anyway. So if you know anybody who's thinking about taking these drugs, warn them off. Anyway, that's all I have. If anybody has any questions.
Thank you so much, Dr. Molchan. If any of the students first want to ask any questions, you can just raise your hand. Oh, Hannah, of course, go.
Hi, so I know you mentioned that exercise may be a preventative behavior. Are there any other ones as opposed to taking medication that you know of?
There's lots of modifiable risk factors for dementia. There's an official kind of not really study report put out by the Lancet that was just updated this year, and there's 14 of them, and that's kind of the basic things like keeping your blood pressure under control, your cholesterol under control, diabetes under control. I should have mentioned that actually about the costs for these drugs. The latest one approved, donanemab, it costs about $49,000 a year. That's the total, though, for treatment, which includes blood tests, the PET scan, MRI scans for monitoring for the brain bleeds, is $82,000 a year. The US is the only country so far that's been duped to approve these drugs, as far as I know. And Adrian, I don't know if others so far. I know it's being considered in other countries, but we're the only ones that have approved them. Last I looked. Medicare, because they're used in older people, Medicare are the ones who end up paying for these drugs. And Medicare does not have an unlimited unlimited pot of money. And that's what's so sad, that a lot of elders can't afford their drugs that work for these modifiable risk factors, which include treating their hypertension, their diabetes, their cholesterol. And getting their hearing aids. I know Medicare doesn't pay for that right now, but things like that. But yeah, I'd have you look at the Lancet report. There's like 14 of them. Early childhood education, growing up in a polluted area near a highway, getting those heavy metals in your brain. There's a lot of them that if public health, if governments were able to modify these, dementia rates would fall by 40%. It's really significant. Those are getting a little more press than they used to, fortunately, but still not enough. So there's a lot of things. Social connections, I should mention, because that's a big thing, maintaining social connections as you get older.
Other questions from students before we open it up to everyone else?
I have a question, not necessarily related to dementia, but your fun fact had to do with hiking. So I also love to hike. I'm curious where the best place or your favorite place you've ever been to hike was.
Oh, well, around here, there's lots of great places. We're right near Shenandoah Park, right? And I'll put in a plug for the hiking club, the Wanderbirds. So you can check that out on Meetup.
Also a member, I'll second that.
I just came back from the French Alps. That was good. I don't know about a favorite place. Yeah, I really enjoyed the Chamonix Valley. Hmm.
So how about more questions from students? Any more? Raise your hand and Chet will call on you if there are any.
And
Yeah,
chat, there's
Aubrey.
also a lot of questions in chat.
Oh, okay. I'll look at that. But first, Aubrielle, you can ask your question.
Oh, yeah.
Hi, thank you for your talk. I was wondering what age you suggest folks start. I think like preventative care is a lifelong process, but particularly with Alzheimer's and dementia, what age do you suggest folks start paying more attention and making more intentional efforts?
When they look at the studies, they say middle age is super important for all of these things. Of course, it's really hard to get data, the longer it's really hard to get data on people and good data the longer you go back. So, they may not have good data on younger people for one thing. But they know that middle age, it's really important to have controlled your blood sugar and your cholesterol and your blood pressure. And to be physically active, have your depression treated, all of those things. Probably I'm sure, the younger the better. Um, you know. develop good eating habits. There's a big push now on the ultra processed food, right? That can't be good for any of us. Fruits and vegetables, the Mediterranean diet, they have shown, the Mediterranean diet is really good, which makes sense. It's the beans and the fruits and vegetables, fish, little red meat. So not too much alcohol.
Someone in the chat asked,
Yeah.
It says, Daniel Alkin, PhD, told me several weeks ago that his animal models of Alzheimer's show cure from an experimental monoclonal antibody therapy. Does that sound promising to you?
Well, I mentioned early on that the animals have been cured. We used to call it Alzheimer's disease. Have been the mice have been cured time and time again, and so it was really hopeful that these drugs, these monoclonal antibody drugs, anti-amyloid monoclonal antibodies drugs would work in humans, but they just didn't, like they did in the mice. Mice are not humans, and they have different brains, different nerve cell connections, and they just didn't work for whatever reasons. So some people have talked about whether we should even be using the animal models, nothing to do with humaneness, whether we should be using the animal models anymore in brain disorders. They just haven't crossed over very well.
Okay, and Peter Whitehouse had a question too. If
Okay.
you want to unmute yourself.
Thank you.
Yeah. Yeah, we can hear you.
Hi, Peter.
Thank you, Susan. That was great as usual. Some countries have been a bit more amenable to approving them. The UK, Europe has not, but UK did. But the same day that their regulatory body approved the drug, their National Institute for Clinical Excellence makes decisions about whether
Right.
the government should pay, said
Right.
they wouldn't. So I think
Okay.
raised important issues about
Yeah.
whether it's worth using any circumstance or at what cost. But here's my question to you, and then I'm going to make a plug for something.
Yeah.
Well, actually, let me make a plug for something. Right now, we're in the middle of a series on cancer and Alzheimer's disease in a group called Concilium Scientific. And if I weren't on my phone, I would send you a link because that's free and available for people to enter in. And the conversation I'm going to be moderating is on the FDA. So here's my question to you, Susan, so you can tell me what to say next month. You've seen it as a clinician, as a researcher, as a regulator. Where are the changes that we need to make? You've described the problem, but what's the solution, or where would you emphasize where would you prioritize effort to improve the situation so we actually can have safe and effective drugs? Thank you.
Well, I don't think drugs are the answer. Right? Peter?
No, I certainly agree with you. I mean, the question is,
yeah, I know you do.
Yeah, I don't want to overemphasize the drugs, but I wanted to, since that's the FDA's role, how can we improve the FDA is my question.
Right. And Adrian Pharmed Out put out a really nice report. Was it this year, Adrian, it came out, or last year, on what needs to change at the FDA?
Just came out a few months ago. I'll put a link in the chat.
Yeah, that went into lots of detail on
Problems with the FDA.
not just what's wrong with the FDA, but what can be done to make the FDA better, because the bar for approval of drugs at the FDA has really gone down since I worked there 20 plus years ago, and they're approving drugs that don't work, not just in Alzheimer's disease, in multiple dystrophy, in many many diseases. It's one thing in cancer maybe, but then when they do get approved even in cancer to try to get them off the market, oh, that disease for premature labor. I mean, it's just crazy, and it's they all have side effects and they all cost money, and it's just not right. So I would yeah, look at that link that from Adrian is the most important thing regarding the FDA. Regarding the cost effectiveness of the anti-amyloid drugs here, there have been a couple of, at least 2 papers on their lack of cost effectiveness in the United States. One that came out this year by Caleb Alexander, and one in 2022 by Eric Ross. How could they be cost effective if they don't work? Anyway.
Do any other students have questions before I open it up to the larger audience? Okay, John, the floor is all yours.
John Anderson. That you
John
mean?
Anderson.
So I was a
Yes,
student at Hopkins in 1970 when Guy McCann, the first chief of neurology, presented a case of Alzheimer's as something extremely rare.
Right.
It wasn't until 76 that Katzman
Yes.
put out his paper saying the 4th or 5th largest cause of death in the United States, and we don't even.
Exactly.
At any rate, my mother got Alzheimer's at 72, so I'm a physician. So there was a person at Hopkins who was involved in the original Tacron study, not about amyloid, but
Right.
and it was clear in talking to her that there was a great effort on the part, I think it was Park Davis, I don't remember the drug company,
Yeah.
to find an outcome measure that looked good. That
Right.
likely to be positive, whether you hand waved over them or said a
Exactly.
prayer to God. And I think that's continued now. That lots of the outcome studies are things. Man, I could do just as well with holy water.
And that's exactly true. And Adrian and I wrote a paper a couple of years ago, kind of comparing the outcome of these new drugs with the old cholinesterase inhibitors. They're using the same playbook, essentially, but you're correct. And it all started with Katzman. My mother used to say that, oh, I never heard, when I was working in the field, oh, I never heard of Alzheimer's disease. And yes, it's Dr. Katzman, and it was called the politics of what was it, Peter? The politics of misery, the politics of whatever. Anyway, because
Politics of anguish. That was
the
Bob.
politics of anguish. They needed to draw attention to it. They needed a disease to draw funding towards it, and to make it more specific. And anyway, that's yeah.
I put a link to the article in the chat earlier.
Yeah. Anyway, but yes, that's very true. And they kept fine tuning the outcome. And I watched this. I was in the field for 30 years, and I watched this kind of with dismay that, oh no, they'll never approve this. And of course, I'm sitting there. I have no idea. My colleagues are taking all this money from companies, and I'm just sitting there raising my 3 girls, thinking, how do they have time for all this? I have a job anyway. But so yeah. But yes, it's a very similar scheme, and it's unfortunate Medicare. I mean, it's our tax dollars that are paying for this stuff.
Seth, call in some more people.
Okay. I don't want to mispronounce your name. Yeah.
Leonore. Just say
Leonore.
Leonore.
That's
It's like Lenore, only with an O. Leonore.
Okay.
So my question goes to other changes over these years. in particular, the development of the industry support to patients for paying for expensive drugs. You know, like the Lilly Cares Foundation. I just picked that name. So, you know, I've been following the sex story, as you know, and really interested in the whole issue of patient-supported drug development and patient involvement in the FDA for that matter. But only recently have I started getting curious about the role of industry giving free pills to patients who can't afford to buy them. So I really think that has to be part of the story. And it must clearly be part of the Alzheimer's story, don't you think? And are there angles to this that you know about?
Hi, Leonore. I don't know. I know they do it. How much they do it? That's a good question. Yeah, that's a very good question.
Well, I can answer the thing about giving free drugs to patients, which is that the one thing that industry fears more than anything else is government regulation of drug prices. And so they would much rather give away a small amount of drugs to people after making sure that they're ineligible for every government program. But it's a means of keeping government away from possibly regulating drug prices.
Right, and it would be a tax write-off for them, I imagine. But how
Yes.
many patients they actually do that for? They certainly don't do it for people who need insulin. I mean, we heard about people, you know, dying who couldn't get their insulin. So I don't know how much of it they actually do.
Yeah, well, that's sort of my question. I'm thinking of a graph, you know, showing the rise of, you know, disbursements to patients from these foundations correlative with, I don't know what, the
It's
number
hard to
of
get
drugs
information from,
approved or,
and it's hard to get information from companies. I wonder if they would, because of what Adrian said, whether they would make that information available. I don't know.
I think somebody ought to be looking at this because from the patient's point of view, it seems like such a windfall and such a lucky thing, and they don't really connect it to any of the larger political issues at all. It's sort of like, you know, your story of the amyloid plaques. It just seems like a scientific fact, you know, and they don't connect it to the larger picture.
There's a question. Honestly, there's a lot of questions in the chat, but I'm just trying to get to as many as we can. There's one.
Lisa Vertinsky has been waiting for a while. Maybe have
Oh,
her.
okay.
Yeah.
Yeah, you can go, Lisa.
Lisa, you're muted.
You'd think after all these years I would not do that. Sorry. So thank you, first of all, for your work. I really appreciate what you're doing. And two questions. One, I'm just curious, what are the barriers to getting more publicity for that work on brain shrinkage or some of the other costs that go along with taking these drugs? And the second one, there's been a lot more writing kind of in the kind of law, economics, and business community about trying different measures of the social value of drugs. They've done it mostly in the IRA context to try and sort of, you know, justify price reductions. Is there been any work on trying to measure the health, and you may not know, but the health value of these drugs? Because I mean, it sounds like it's clearly negative even before you
Yeah.
count money spent. And so I wonder if that's a good avenue for academics who are concerned about this to be working
Well,
on.
there have been, like I said, there's been at least a couple of papers on the health economics of them, on the cost effectiveness. One was in JAMA by Eric Ross, and another in neurology by Caleb Alexander. And I would bet there's some in some of the health economic literature. I just did a quick search over the past couple days just to see, and sure enough, yeah, there's at least a couple. So there's some, and I know Adrian and Judy Butler got an op-ed fairly recently on one of the drugs. So we all try to get op-eds out there and letters to the editor, but it's really hard.
I was thinking more on the CMS, right? So I mean, the Centers for Medicare, they can't afford to be paying for these, and so it just seems like there should be a more robust discussion.
It's
on
a
their
shame.
end.
They have to pay for what the FDA approves, is the thing. It's a shame. It makes me very angry as a taxpayer and a physician, because I know these drugs don't help and they harm. But I'm on Medicare now, and my rates will go up. People will be paying more out of their paycheck, people who are working, because of these drugs that don't work. Primary care docs will probably take a pay cut. They don't need a pay cut. Some patients won't be, paying for their asthma drugs or their cholesterol drugs because they can't afford them. It's just crazy. So, but CMS has to pay for them. So this, whether something in Congress the pharmaceutical industry gives so much money to Congress, more than just about anybody. Is the thing.
There's people have asked in the chat about the benefits of semaglutide, transcranial magnetic stimulation, and Chinese medicine. Can you comment on any of these?
Well, semaglutide, that's like the obesity drugs, like Wegovy. Is that right? Yeah. I don't know of any studies. I mean, obesity is is that one of the modifiable risk factors? I haven't had them written down. Yes, that's one of the modifiable risk factors. Yeah, from the Lancet report, along with diabetes, hypertension, decreasing smoking. They haven't looked at those drugs, Wegovy and the other one specifically. So I don't know. What was the other? They've looked at lots and lots of different things over the years.
Chinese herbal medicine was one of the things mentioned.
Yeah, no, is it? Yeah, I don't know. You'd have to look it up and see if there's been any, placebo-controlled blinded studies. I mean, eating the Mediterranean diet, eating lots of vegetables, but there's no specific herbal supplements or anything that have been shown. And they've tried lots of them, like ginkgo. There was a couple of really large studies on ginkgo years ago that just didn't work. Curcumin, I know that's not Chinese, but they've tried studies on that. Again, at different phases of the illness. But the bottom line, there are just kind of common sense modifiable risk factors that that make sense. What was the other one? Chinese medicine, semaglutide, and
transcranial magnetic stimulation.
Oh, yeah, TMS is being used for all kinds of things now. It doesn't even work very well for what it started out to be used for depression. I was using it in my last job quite a bit, and I just wasn't impressed with it for depression. So the short answer is no, and I don't see how it can work for dementia. I don't think that makes sense, and there's not good evidence for that, no.
If I could interject, I want to apologize to everybody for popping on and off the screen during this seminar. It's just a lot of technological problems with my connection, and I'm glad that it went on as scheduled and that it's evoked such a great discussion, including people who have been here before to give seminars to our groups. But I have a random thought, Susan, if you wouldn't mind commenting on it. You don't have to, but one of the things that worries me is the glut of stuff on the internet about medications that one can purchase without seeing a doctor, without proper documentation. And largely it's been for things that are either vanity drugs or drugs of abuse, and now weight loss drugs. But we can all see where this is going.
Yeah.
Does it worry you that one day that some of these drugs for Alzheimer's is going to pop up somewhere as something you can buy on the internet? Because it's something that so many people are afraid of or are dealing with in their families.
Yeah.
So,
Well, the current drugs are, I should have mentioned this, they're administered by intravenous infusion. So they're not so easy, and they're given every either 2 weeks or 4 weeks for one thing. And only certain doctors or certain neurologists are able to give them. So no with these specific drugs. But kind of the fountain of youth, the whole memory thing, has been around for a long time. There's always been drugs marketed for that, for improving your memory and things like that. We see them out there all the time advertised. People used to ask me about them in my practice. I would show them the studies, and there's always going to be things like that. These potions and things. I mean, the evidence really isn't any better for the drugs being marketed by approved by the FDA is what's so unfortunate. But people need to be better educated on how to critically evaluate information in general, right? And hopefully that'll happen someday.
okay, thank you, Chet. Maybe we have time for a couple more questions from the chat.
Yeah, from Gary Schweitzer. Public relations and advertising professionals are paid to please their clients, but journalists are supposed to independently vet claims and evaluate evidence. Can you discuss the role of journalism in addressing some of these concerns?
Hi, Gary. Yeah, some of the journalists do a better job than others, as we know. And I've been pretty disappointed in the way the journalists have addressed these drugs. They kind of parrot what they're told by the drug companies and say that these drugs, slightly slow progression, and they just don't go into the details of the statistical versus clinical significance. And I realize the pharmaceutical companies are also their advertiser. Unfortunately, I have to think that's a big part of it. I just see it time and time again. That's the only thing I can think. It's very disappointing with these anti-amyloid drugs. But we need something like health news review. Health news review. I used to work with Gary on a publication that used to call out journalists to be more critical of what they're being told about about findings about new drugs, about what's in the news, because people just don't evaluate, critically think about what they're reading in the news. But that small publication isn't around anymore, unfortunately.
And it wasn't that small. We were reaching more than 1 million unique visitors every year.
Yeah.
And Susan, it's great to see you again and hear from you, because your voice is so important on these issues. So for 16 years, Health News Review, with foundation funding, daily reviewed the quality, usually the lack thereof, in not only journalism, but public relations and advertising messages. It couldn't go on forever. Our funding ran out. It's really sad that no one stepped up to fund it, but let's face it, you can't run from this. We pissed off a lot of people when every day, when you're reviewing journalists who, and I've been a healthcare journalist for 50 years, and journalists are not used to being reviewed by independent sources. They often aren't even reviewed by their bosses adequately enough. And so certainly neither were PR and advertising people. And in reviewing more than 6,000 media messages with systematic criteria that we applied to the review of these stories that made claims, the grades were abysmal on things like, all right, if you're talking about how wonderful something is, did you adequately mention costs? Did you adequately discuss, and by that we insisted on quantifying in absolute, not relative terms, benefits, quantifying harms. So how big or how small are the potential benefits and how large are the potential harms.
Right.
And on all these things, well more than 50% of the stories, in the eyes of independent reviewers like Dr. Molchan, got unsatisfactory grades. So I asked my question and chimed in here because I really think it's important for the students to realize there actually is a career path, I would hope, for young people like you to maybe pick up the sword on what we tried to do for 16 years and had a hell of a good time doing it. And I think really made an impact on public education and trying to help people improve their critical thinking. Because when you just think about the daily impact of advertising, PR messages, television, the internet, it's not well done or not well done journal studies that are directly reaching the public. It's PR about them, advertising about them, and shoddy news coverage about them. Right. So maybe some of you will pick up that charge in the future. I'd be happy to talk with anyone about it.
Yeah, thanks, Gary. Yeah, you took no advertising, and that made all the difference, right? That's yeah.
Well, Dr. Molchan, I just wanted to thank you on behalf of the HAPI program and just thank you for taking the time out of your day to come speak with us today. We learned a lot from you, and thanks for everything that you're doing too.
All right. Thank you, Chet. All right.
Thank you all for coming.
Yeah.
Hope to see you next time.
Take care.
Bye-bye.